and watched her walk. She didn't get like any hip extension. She was all like getting all of her hip extension almost through like the L5 and like the sacrum. Looked at her QL, super tight, had like no rotation. So again, did some T11 mobilizations, did some of the soft tissue stuff on the QL, and like her gait like changed within like 10 minutes of doing that stuff. It's kind of crazy. And then pain too was like drastically down from when she walked in. So it's just stuff that she probably did have like, I was thinking she had more of like an SI joint dysfunction, but it was like what's driving the SI joint dysfunction. All of it was like super applicable like right away.
Yeah. So like, with her, it's that the primary is probably, L5S1 or SI joint as the primary thing. So we're looking at this clinically, that's the primary driver. And then, hip, TL junction, or your next kind of two motion segments, and looking at the etiology chain, certainly could be the L4, L5 above it. But when you see that hypermobility, that L5S1, and she's extending through it, then the motion at TL junction, and even look at the ability of the thoracic spine to kind of counter rotate, as I'm sure Eric talked about in gait, would be a key factor in that individual. To say, do you end up manipulating any of these patients, or are you just able to do it with mobilization and movement training?
I did a manipulation on the first guy, and the second one, she was osteoporotic, so we just did mobilization.
Yeah, what did you do for her?
I just did some like some end range, just mobilizations like in the plane of the joint, and then we just did some like movement training, did some like the archer stretches that we had talked about in class, and that seemed to help out quite a bit.
Yeah, and oftentimes I'll get in and just it's using the you talk about the arthrokinetic and osteokinetic motions, guiding that person in that lower thoracic spine through them is sometimes helpful. Whether it's just a joint mobility or even just kind of getting a sense of that motor control through that region to get TL junction. So oftentimes just using that caliper grip. There's my hand. There it is. Using that caliper grip on there. Funny, my camera's like reversed. It's messing me all up. There we go. And just kind of taking the ribs and being able to kind of guide them with my hand. So as they right rotate, just kind of guiding the right and the left rib through their plane. Another one I'll do, and I was doing with Tim yesterday, was doing the, basically blocking the lower rib. And by blocking the lower rib is almost the test for the translation. I can have the upper segment move. So I can mobilize with active movement by locking, let's say I lock a T10, and then I can have T9 rotate above it, is almost the test in the translation. And so for the osteoporotic patient, those are nice techniques. I often will play with those even early on, just when I'm looking at somebody, just to see, okay, does this free them up, or is, it kind of tells me, okay, is this really manipulable? Or many times, some of those people, you can kind of even get them loose with that. It's enough to free the joint up without having to manipulate it. So that's the osteoporotic ones are really nice when you think with these techniques, because when you think about it as only being manipulation, then like, okay, well, this is a 75-year-old woman who's frail. I'm not going to use any of these techniques on her. And it's just so not the case. It's use the biomechanics that we discuss and the joint mobilities, and you kind of work through them. And I think that's even more valuable. Manipulations are fun because they're quick, but just having this kind of arsenal of techniques is super valuable. Cool. What would you like to do more of? Go ahead.
If you're going to mobilize upper thoracic on an osteoporotic patient, are you doing that from a seated position where you're taking them into the joint glide, like how we were testing it? Or
I'm more
probably
am. I think my tendency is to do it that way, because prone, I will do it prone, but I'm very, very careful. But if they're osteoporotic, I'd rather have them sitting and kind of do it with natural motion, where I'm just adding end range overpressure for the most part. Versus, let's say, if it's like when you learn the rib manip, it's like laying them on my thumb. I can do the glides and translations that way by laying them on my rib and just gently mobilizing them in an anterior medial or posterior lateral direction. But still, it's just a matter of who are they, how much force, and where's my comfort level. So I think I've gone more to seated because I think it's less noxious on them. It's less risky. I think early on I was more prone to take more risks or just have them do the prone technique because I wasn't as good at feeling the joint mechanics. what area, Tanner, coming away from that, would you think would be okay? What would I like to work on next? Like, what would be the one area coming out of this course? Like, boy, over the next 8 weeks, it would be nice to tie this together, whether it's work from the other courses or, work from the thoracic course.
I was cutting out on my end. Can you repeat that for me?
I was kind of curious, like if you were to think over the next 8 weeks, like with the thoracic material and the lumbar and cervical, what would you think would you like to work on over that period of time personally?
I think it'd probably be a combination of like the lumbar and the thoracic. Just 'cause I feel like the cervical, from like a execution standpoint of like mobilization stuff, I feel like I got a pretty good on that. The lumbar, I just feel like I haven't had a ton of lumbar patients. So practicing the joint slides and stuff, I'm trying to do it on like support staff and like some of our patients that are appropriate. And then the thoracic, I just want to get better about executing the like techniques and the exam principles that we went over in the courses. And that's just going to take repetition.
Yeah, that's the key now is after the thoracic course, there's just a ton of techniques, wasn't it?
Yeah.
Yeah. So compared to the other courses, like the peripheral is the same exact way. It's a barrage of techniques. And the good news is that the next 4 courses, you get plenty of chance to practice them. So it's not like, okay, boy, I really didn't fully get that in the thoracic courses. You're going to get a chance to go over it and go over it and go over it. So no one beats yourself up if you feel like, oh God, I can't remember everything that just happened. But it's that idea of, okay, kind of set a goal for yourself of, okay, I'm going to look at the lumbar TL junction relationship over the hip and look at your patients and think about gait, because gait's a wonderful one to now bring it back into. We talked about TL junction and activation. So you're looking at hip range of motion, what's happening at the innominate, L5S1, TL junction. Those are nice places to kind of go. And like even with one of the fellows, Tim and I, we've been working on, it's an ankle ORIF that's really jacked up and he's got a super tight ankle. But one of the most gains he's made has been working on his TL junction and his thoracic spine, because he's been jacked up for so long. You can see all the hypertrophy on his right-sided paraspinals from it. So by improving his thoracic mobility, even with his ankle fracture patient, it's done a lot to improve his gait and getting him to translate his tibia over the talus. So that's where these things are cool when you take it back into the gait cycle, because now it's every patient and how they're moving. How are they moving across their knee? Can TL junction and thoracic spine impact kind of their knee? So it's where, as I say, set goals, kind of think about it. All right. How about the other Tanner? Tanner Newberger, how was your experience?
I think it was good. It was nice to get some of those techniques for the TL junction and QL region. I've been able to use that actually pretty quick with my patients since coming back from the weekend. I had a guy who's got some left-sided lumbar hip issues, and he responded pretty well to just some general lumbar manipulations and mobilizations, but there's always been like a nagging issue there.
Yeah.
But I was able to check out. He had a lot of QL tightness and instant pain with just a little bit of pressure. Ribs weren't moving there at 11 and 12. Did some quick manipulations to that and just completely immediately after.
Yeah. Good. That's a chicken or the egg one, where you're wondering, is the subluxation restriction then changing the motor pattern? And some of these people, you'll find that the restriction will be the motor pattern is off, that the muscles are pulling them into this position. So you always keep in mind too that, not all these ones will be the purely manipulable lesion. It may be a myofascial, restriction in that segment or a rotation. But it is pretty nice when you get in there and you can find their restricted ribs, kind of manipulate them and see the pattern change. How did you see differences in their walking, Tanner, or any other movement patterns that you looked at? Tanner's probably talking into his muted mic.
Oh, yeah, sorry. I just had it on mute. He had a lot better rotation with his lower thoracic and upper lumbar spine. when he was walking, so it was no longer a stiff type gait. He was able to get everything through.
Yeah. Did you notice any difference like in arm swing?
I felt like he was swinging his arms more afterwards, but that could have just been my bias wanting to see that.
Yeah, it can be hit or miss because gait is such a just such a centrally driven thing. That's one thing I tend to look for, is that this is the patient who many times you see going side to side. So you're thinking, oh, is it a Trendelenburg? But their gait, they won't have much arm swing because you elect that TL junction thoracic rotation. So the arms stay more by the side, the center of mass shifts right and left more. You got many things which can drive that, but this is certainly one of those things that can do that. So in that individual, I wouldn't be surprised that you just see them move and they look a little bit more free. This is often, many times, much more apparent in runners. So when they have this restriction, it gets amplified by the running mechanic. I just see, and it'll usually be like a, they'll move much better to one rotation than the other. And you can see that out there, if they're awful in their right rotation, the ability to rotate their TL junction, thoracic spine is diminished, how it's going to impact, what they're striding with, even in the opposite leg at any point in the gait cycle. So runners are a good one to think about, hip TL junction relationships. What we see. Cool. Anything else cool in there, Tanner? You like to add? Or you took away from the weekend, or what would you like to work on kind of going forward?
I just had a quick question about one of my patients who's got some shoulder impingement going on. Noticed some CT junction issues, was able to manipulate that and get her freer. So her shoulder range of motion was better. And the painful arc shifted from being a normal impingement, painful arc right around that, 90 to 120 to full extension, that full flexion is when she finally got that pinch back. So I'm assuming that's more or less just shifted a little bit because she can move better.
Yeah. Did you happen to take we went over the clavicle a little bit in the cervical module. Did you happen to take a look at the clavicle to see if it was lacking any of it should have a posterior roll that occurs toward the end of motion? Did you happen to take a look at that?
I did not, but I got her coming in at 5 o'clock, so I'll be assessing that tonight.
Cool. So I want you to take a look at that. Is you could, a little bit of real quick and dirty, that's the SC joint mechanics. Is if I do a shoulder shrug and just kind of lift my shoulders up. I'm sorry, I can't see myself on camera. If you can see it, if I do the shoulder shrug here, SC joint motion is mostly at the clavicle and disc joint is where that motion tends to is occurring mostly. As I get to end range shoulder motion here, what has to happen is then the disc and clavicle move on the manubrium. That's a quick thing. So you just want something to kind of put in the back of your mind for when we get there. It's there. But what should happen with that is a posterior roll. I often describe it to patients like this. I put one hand in my fist, my other hand here, and I say when the shoulder elevates, it has to spin. And so they can see my knuckles turn. So I get to the end range here, I have to have the spin that's going to occur. The posterior roll, which will then decompress the shoulder at elevation. So you think of the elevated position, what I'm looking for is that, do I have the thoracic spine contribution to the motion? And then, okay, what is my clavicle doing relative there? It could be stuck at the AC joint or the SC joint. If it's the SC joint, just try, distraction at the SC joint. It's the quickest and easiest one. AC joint, if you're comfortable with it, you can use the thumb manip technique, which I believe if we don't do it next course, we'll do it in 6. That sound like a good, give you a little something to work with?
Yeah, I think so.
Yeah, so it's kind of nice to assess it. The rolls I see lots of times restricted. And again, it can be SC or AC joint driven. And that if you improve that roll at the end, you also will take that pressure off in that finish in the overhead. And again, also remember that is also usually coupled with lower thoracic extension. So you're almost coming back now to lower thoracic TL junction region. That individual as another source of, as they get up in that end range position, are they able to then extend through that joint, or is it all glenohumeral and not, lower thoracic and a clavicular roll?
Hey Dave, I've got a question kind of about that.
Yeah, Mark.
So I've got a patient in right now, actually. She's a runner, just kind of fitting the description that you're talking about, where um, she kind of presents with right shoulder pain, right hip pain, right knee pain. And I've kind of worked through what's going on with her, a little bit of a nominate rotation, maybe a right up slip a little bit, and then she's hypermobile right, like thoracic spine at like T5, T6. So worked on that a little bit today with her. She's making good improvement with the shoulder symptoms, but obviously there's a lot to work together. It's only been 4 visits with her. Just kind of wondering how like your process for where you start when there's multiple areas like that.
Walk me through it again. Start with what you think is the primary driver.
I initially thought it was going to be more of the hips.
Okay.
Because she was rotated and she had that upslip. So I kind of thought that was the initial, and kind of compensating through her thoracic spine. But it makes me question that with what you mentioned about, just the runners and the rotation, because it's exactly what you said. She's limited in rotation to one direction. So that's where I guess I'm kind of a little bit puzzled as to, when I look at the whole kinetic chain, where is it breaking down?
Yeah, where's her primary pain again?
The worst of it was actually at the shoulder. She came in because she was running, and she's got a long chronic history of right hip and right knee symptoms. She wasn't too concerned about that because she's always kind of had something there, but she started getting the aggravation in the shoulder, which was really irritating her while she was doing longer runs.
Where in her shoulder was the pain?
Posterior, like medial scap border.
Okay, is it posterior glenohumeral joint or more the medial scapular border?
It's not really glenohumeral. It's more on the scapula.
So I'm just writing some of this down so I can keep track. Okay. So did you watch her run?
I have one time, yeah. And there wasn't a whole lot that I picked up there. And I think that's more just my comfort level with the gait analysis, and I didn't slow it down or anything.
Yeah, sometimes if I know there you have all different restrictions on what you can video and how you can video it and where you can store it. So I understand that. With her, you're right. You want to it's getting that sense of with her, it's which joints are involved in this region. So we're looking at medial scapular border. I want to see, is she rounded forward at all? And is her rotation more of an arm swing versus a thoracic rotation? Does that make sense? You have those runners there'll be a lot of glenohumeral motion, which the scapular will have to control a bit more, versus those people where the rotation is TL junction, thoracic spine. It kind of moves to the system, and the arm is just more part of the driver. It's not the primary driver. So if she's getting that medial border pain, again, certainly I'm going to go in there and I'm going to look at ribs mobile. Do I have a restriction anywhere in there, which would be a point of tension? But more likely, maybe scapular position and the way she's loading it. And that comes back again to where's her body rotation. If she's having a hip and knee issue, then chances are there is a body rotation issue, because she's going to be, she's going to get an antalgic pattern in some way loading through the hip or knee.
Yeah.
So, is it going to be a compensation? Did you say it was her right shoulder or left shoulder?
Right. Everything's on her right side.
Okay. So right, and I can make a reason up either way. If you said right or left, quite honestly, you can make up a story that would probably fit with that, and how she's doing it. If she's, is she over rotating through the upper thoracic spine to try and generate speed and momentum for the leg, to kind of pull the body through? Does she lose, with her, one of the things you look at, does she lose hip centering? If we go down to the hip, is she getting an internal rotation moment, any pelvic drop, or can she keep her hips centered through the gait cycle? Would be the key. Because if she can't, it's going to affect the rotary patterns coming up. Because you can kind of see it where if somebody has that internally rotating hip and collapsing, it's generally going to reduce the length of that leg, and you're going to get a compensatory rotation, probably up TL junction, thoracic spine. So, if you want to play the hip off of the thoracic spine, I'm going to look for on that right side, does she have good motor control of the hip and foot? And anything that's going to create a collapsing moment, a pelvic drop, or just a descending moment, is going to create an excessive rotation moment in the upper extremity. And I often start by, can I eliminate the excessive rotations that may be occurring, and kind of bring somebody kind of back to more of a neutral position? Is what I'm going to look for with her. Also, it's what am I seeing? If her thoracic spine is stiff, is she trying to generate that arm or upper body motion with, glenohumeral or scapular thoracic, swing? Is she using the upper girdle versus the thoracic spine to generate the momentum?
Yeah.
Does that make sense?
Yeah, definitely.
So kind of, if you want more of a summary of that, look at the running gait or even the walking gait and see, is the thoracic spine moving symmetrically, or is she using more of a shoulder strategy with gait cycle?
Okay.
And you can look at it. I would look at it locally and see what it's doing. I would also look if she's running, if she has any increased flexion through the upper thoracic spine. Is she a huncher as she runs? It's gonna bring the scapula into a protracted position, most likely. And if she's hanging from that position, it's going to be stressful on levator scap or mid traps or rhomboids. Something has to now fix her scapula in that position. So if you're looking at a myofascial pain pattern, I would look for a stressor that's going to be that way. What's getting overused, and also, again, mechanically, can I get her upper thoracic spine centered and stacked? So if she's got an excessive hunch, that'd be one thing. So I want to stack her spine over top of her pelvis. Now, that said, she could still have a forward lean. By stacking the spine there, it doesn't have to be straight perpendicular. She can be leaning forward this way, just maybe not at the hip joint, where she then rounds her back. So when I look at a forward lean in a body, I want it to come from the ankle joint, not from the hip, because then the hips push backwards, center of mass changes, and then she can be hunching, would be there. Hips, again, I want to eliminate excessive rotation in the hip joint, and that will reflect upward.
Okay.
So if she's having that's your standing assessment of, okay, where's her hip in space when she stands, when she squats. Your single leg stance test would be the one that would probably give you the most information there, is when she goes to load in single leg stance, does her femur internally rotate? Does she lose SI joint control when she goes into single leg stance? And then, from there, I generally will play with, pelvic floor contraction. Do I need to go from short foot? Or if you really want to play with this, you see, this one can also be coming from the thoracic spine. So as we get into modules 7 and 8, we'll get into thoracic spine drivers of the hip and pelvis. Because if you think about it, if your center of mass is shifted in your thoracic spine, again, it's an uneven weight distribution, and your whole muscular pattern and your load transfer pattern can be failing from the thoracic spine position. But it's a bit deep to go into probably right now. But you can kind of get an idea of it just having taken the thoracic module or thinking about going into it. How does the thoracic spine and the center of mass shift in the thoracic spine impact loading through the hip and pelvis? And really is bring her back to neutral, Mark. Take a little, if she's not rotating enough in thoracic spine, add a little thoracic spine rotation. If she is, collapsing through the hip, can I limit the amount of hip, uncontrolled femoral internal rotation? She may not be somebody who's subluxed, but she just has lost the dynamic control of the internal rotation moment. That would be my bet. And occasionally when she gets the hip pain is when she's probably subluxed. So with these hips, they'll phase in and out of these subluxations. So you may not always see it. She may come in 3 times and not be subluxed. That 4th time she comes in and boom, there it is. She's, 30 degrees of internal rotation. And that's where that, yeah, she's subluxed and I can fix her here, but I'd have to work on the motor control pattern around the hip as well to get the hip to center properly.
Yeah.
Again. And the knee is the monkey in the middle. If you want to play with something with the knee, I would look at the screw home mechanism in terminal knee stance. when you have her, just when she's standing, when she unlocks her knee and relocks it, check and see if she does that in the early squat phase. Is that as she goes to extend her knee, you should have the lateral rotation of the tibia and the medial rotation of the femur. So sometimes it's really kind of crazy in people with somebody who can't control their hip, it reverses. So what you'll get is a reverse screw home mechanism. When they go to extend their knee, the tibia will internally rotate. And when they start to squat, instead of the tibia internally rotating, it laterally rotates, which can stress the knee. So just think of it's, if I palpate that, it's kind of rest one hand on the femur and the other hand on the tibia. And you just have them flex and extend and feel like, okay, I feel the screw home mechanism. Do I feel the lateral conjunct rotation, the lateral rotation with extension? And does it reverse when they come immediately in the first 15 degrees out of extension? If you note that, then your driver is probably the foot or the hip.
Okay.
If it's all confusing, just come back next week with information and we can kind of tease through some of these systems.
Okay.
Does that make sense?
Yeah. I mean, definitely a lot to look at. So.
Yep. So watch her run again,
Mhm.
stack her spine, look for excessive internal hip rotation, either coming from the foot or the hip. You will know it's the hip if it happens early. The foot, you'll see the foot collapse as they start to get in the mid-stance loading phase, and then the hip will follow. That'll be a foot-driven hip. When it's the hip, it happens almost immediately when they start to kind of load. The hip will internally rotate and they'll lose it. So if she has that, I would correct that first.
Okay.
If you see her center of mass is any way altered in the thoracic spine, get her stacked tall.
Okay.
So that she's got her manubrium and her symphysis pubis in line in a way that she's not punched and bent. She's more stacked. She can be forward leaned in a more aggressive position as she does it. So then I would then, watch her run first before you do anything to her, and then go kind of assess the joints. It's a fun way if you do it, because then sometimes you'll pick up that, oh, I saw that when she ran, and then I see that this joint is stiff. It doesn't always work out, but it's a good way to do it, because if you manipulate it and fix it beforehand, then you have less idea of what if it is a driver or not.
Yeah. Okay. Well, thank you. I'll look at that.
Yeah, because it's the forward lean. You can also get a concept of, a lot of people with the humerus is sitting anterior in the glenoid. That's going to pull and protract the scapula as well. So anything that does that would give her that mid-thoracic pain.
Okay.
What else am I picking on here today? Does anybody from the class or anyone else have anything case in that realm they'd like to discuss? If not, then Drew, buddy, you're up. Drew, how was your experience? The real Drew. Not the fake one.
I think the thing that I took away from it the most, what I took away from it was connecting dots. That was the big thing to me from lumbar, cervical, and thoracic. That gate into it, being able to look at it all from kind of a single point of view and not individually as much anymore. We'll apply it last night with a patient that is dealing with, some Achilles tendinopathy and just general pain, and incorporating the idea of latection during gait.
Mm-hmm.
And he was, I think he was lacking at the left leg action, and if he's not, I explained to him, if he's not getting into that moment, you're pushing through your calf potentially more to create that momentum, because you're not rotating through your thoracic spine. And then the idea that if you're not dispersing the force through there, you can increase the force through the lumbar spine and connect all these dots for what could potentially be causing what he's feeling. So I went in and did one of the latection manipulations, and had him, do a couple different rotational rotation exercises to kind of work on that motor pattern. And we'll see kind of where he's at next time he comes in. But responded really well initially with that.
Yeah, it's kind of cool, isn't it?
Mm-hmm.
Yeah, that is literally like, module 7 and 8. And that you can look at these distal limbs and how improving that trunk rotation is going to unload, the Achilles either in mid to late stance if he's not getting that forward momentum driven from there. You will also see that when they get these rotations or these things in thoracic spine where their center of mass gets put off, it's also a cause of collapse in the foot. And so you can see plantar fasciitis patients that can be thoracically driven. So keep that in the back of your mind. We'll do a bit of that as we get into, again, the later modules. But the simple concept is that your thoracic spine is shifted to the right. It's going to rotate your pelvis and your foot. And it can collapse your arch. And that's where you'll see the plantar fasciitis or potentially the Achilles tendonitis or posterior tib tendonitis. So I'm not going to say it's everybody, but you're going to find these cases where you clean these things up and they will do better. Bad news is that they've given themselves a tendinopathy in the meantime, and you still have to manage the tendinopathy. But you can have these drivers that are a little bit distal. So the TL junction is a good driver when you look at the Achilles tendon or plantar fasciitis patient. And it may not be the first visit you do it on, depending on your comfort level with the patient. But it's that good second level thing that you look at because you watch them walk a little bit in clinic. That second visit, you can kind of go into it. Or what I often do is I'll introduce it at the end of the first visit. That next time you come, we're going to look at your gait cycle and we're going to look at components from your thoracic spine in here. And I'll explain to them why these other functions can impact your gait and your Achilles and where we're going to look at it. And here's the good news is that even if it's not driven from the TL junction in their Achilles, they're probably going to turn to you and go, no PT's ever looked at me like this before. So, many times, 1, it's good practice for you. 2, you're going to find things. 3, if you find nothing, you're giving a really high level evaluation to people. And people notice it when you go in these systems that what you're doing is different and that it's unique. So don't downplay that. You don't want to be arrogant because that kind of cancels out your positive points that you get. But, just kind of, impart it in that, okay, this is kind of what we're looking at. And I'll hear that all the time is that, boy, nobody's ever looked at me like this before. And that's a good thing. So don't discount that when you look at them. So, and don't be shy about looking at the TL junction in anyone who has a walking problem. But just, set it up for the second visit if you're not feeling it in the first visit, unless you're absolutely sure it's TL junction and you don't want to wait. Drew, if you had something to work on between now and the next module, like pulling all these areas together, what do you think it would be?
I think I still want to get better at, connecting those different phases. Just listening to you talk about different things to look at with gait, with a forward lean, and how all of that is incorporated into what you can be seeing. Because I feel I'm still, to a degree, have blinders on. I've seen certain things several times, and so then that's what I start to look for. I start to get biased with what I'm looking at. So trying to not be biased with some of the things I find, whether right now I would say my bias would be the thoracic spine. And I feel like the majority of things right after the course, I relate to the thoracic spine. And, it obviously isn't always that. So that's one that after each course, I need to kind of pull my own reins and say, okay, I need to look at this from a big picture.
Yeah. So it's tying together. I use the thoracic stuff daily. The peripheral course, again, almost every patient, I'll use something from the peripheral course. The thoracic spine, just because you have any lumbar patient, cervical patient, has relevance. And as you saw, as we talked about, I started getting the lower extremity patients. Then I start to need to take into account is there something in thoracic spine that can be a driver in this at some point? And what do we see? So, that'll take a little bit of practice. So if you're not confident they are comfortable with it yet, don't worry about it. Just kind of look at people, think about it a little bit, poke around some. If you're having a hard time tying the hip to the thoracic spine, just kind of know the interrelationships and think about normal gait, and that, okay, when I'm in late stance on my left leg, where should my thoracic spine be? What's the rotation? What should it be? So create some simple things for yourself to look at, like moments or snapshots in time. That may help you. If you're in early stance and loading phase, is the hip neutral? Is it internally rotated? And also where is the thoracic spine in relation? So break it down into smaller things and look at just snapshots in time. See if there's anyone else who'd be fun to pick on. No. All right. We have some time here. Well, this weekend's presentation by Jim, if you didn't watch it twice, it can be kind of hard if you haven't looked at joint mechanics in a while. And the next one presentation he has is getting into some of the peripheral material. I've seen the next two. The next two I thought are really good, but each one, in essence, is information dense. So if I can get out in advance of those, what I'll probably try to do is give you notes on them for spinning glides of joints. And what Jim talked about mostly, with the different types of joints, and just I'll try and clear up a little bit of that if you have some questions on some of the mechanics of those things. And the shoulder joint, the first one, and that's the easiest one I like, because in my mind it kind of sticks out. Is that, and actually Tim and I were looking at this other day, a total shoulder replacement, and because what Tim was doing on him was way more comfortable than what I was doing to him. And the reason why is because I was doing what would be the pure spin in a normal shoulder, and I was doing it because I was kind of curious. What would this feel like? Because you think of a total shoulder, regular shoulder, the humerus is the ball joint, spin this way. Socket joint, is basically on the scapula. Well, they reverse it in the total shoulder. So in the total shoulder now, again, the humerus portion is more the concave portion, and the rounded portion, the convex portion, is on the scapula. So the mechanics are different. In the shoulder joint, if we talk about what is a pure spin, if you're with most every other joint motion, there's a slide or a glide or a lateral rotation that's going to be occurring with most other joint motions. But in the ball and socket joint, with a mechanical axis right in the center, pure spin is in a plane coming across this way. So when I move this way across my body, this is kind of what Jim will call pure flexion, in that there's a pure spin to it. There's no lateral translation. If I go straight up this way, there has to be a lateral rotation of the ball. So not only the ball does it go up, it has to spin laterally. Certainly this way, I gotta really keep it down here. But if I come up here, there's a lateral conjunct rotation that occurs with it. And that's when you think about the ball joints and the spin. But so many times you'll find the most comfortable way to mobilize the shoulder first is across the body in the pure spin, because you're not inducing a lateral or medial rotation in that joint. What Tim had figured out by feeling the shoulder joint is, okay, what's the path of least resistance? If I take this now concave joint on a convex surface, he could find the glide that's the path of least resistance in there. So it's certainly not a pure spin, but he had a much better glide. What I was doing was taking the joint and almost creating like a closed pack position with it. So I'm taking the concave surface and gliding it in a dimension that it doesn't want to go. It's almost like taking it and trying to spin it. So if I take it like this, it's going to move smoothly. If I take it this way, it's going to lock. And Tim, that's what he was experiencing when I was doing it. So I'm taking that surface and creating a twist in it versus this pure motion this way. That's why he liked what you were doing better than what I was doing. But I just kind of looking at it because I was curious on what the plane of that joint would be, just because, again, I hadn't really played with it much. So with convex concave surfaces, there's many things out there, and it's always just think about the glides. The shoulder is kind of the easiest one to think about, in that when I go up, there has to be a lateral rotation to the joint, because the ball joint has to spin laterally as I go up and out. And all I'm talking about is if I kind of move my hand around, I think I showed something in class. My thumb is if my shoulder is internally rotated. The time I go overhead and I come down in kind of the lateral plane, my thumb is facing forward. There's been the lateral rotation of the joint, and that's the lateral glide that he talks about with that. You know, the saddle joint we all know is the thumb joint. It's probably the easiest one to kind of picture in a joint that's going to give you 2 degrees of motion. And hinge and condylar joints are out there too. So I will post some supplementary videos on joint glides for people if they found that confusing, to kind of simplify it. But it's just a good idea to do. I will also put up Jim's, it's a little older manual he had on peripheral manipulation, but he wrote kind of a whole chapter just on joint mechanics, which I think will be a nice complement to what he posted. So I'll see. I may just put that in the top of the fellowship section, and I'll have that up this weekend for you. And I'll kind of link this video if you want to take a look at that with the joint glides. But did anybody have any questions or anything they want to clarify from these joint mechanics? I mean, the key thing to remember is, and we'll get to it when we get into the heel, and we'll talk about the calcaneus. And the calcaneus, you know, really usually talk about the anterior and posterior joints in the calcaneus. And within the calcaneus, you know, the posterior joint on the calcaneus is, you know, convex, and the anterior joint is concave. So you have 2 different joint surfaces. So if you think about the posterior joint, when you have a heel that's in a valgus position, the calcaneus glide was actually medial. So I always think of that when I'm thinking of, okay, which way is the joint glide? Which way does the joint go? So I always think of the convex joint, and I think of a calcaneus that's in a valgus position. And from there, I know that posterior joint has glided, the calcaneus has gone medial, and the talus has gone somewhat lateral relatively in that joint. So that's kind of my mental go-to, just to kind of orient myself. I'm thinking about, okay, the concave convex rules and the glides. Now the calcaneus will be fun when we get to it. Is that with the talus, is that, I don't know if anyone's familiar with the Archimedes screw, but because of the way the joint is kind of set up in that fashion, when we go into like a supinated motion, the talus is able to then ride up onto the calcaneus, and it kind of gets elevated that way. And Archimedes screw is a screw that was designed to move water uphill. It's just by the reverse screw mechanism. It's kind of a cool thing where you can kind of, you know, if the screw spins, you can move water from a lower spot to a higher spot. Calcaneus, because of the joint shape of the concavo-convex relationship, creates this screw mechanism. So for pronation, kind of supination through that joint, you get this kind of cool kind of hinging thing. And I will post a video, and I'm going to go out and find some decent resources to kind of go over some of these joint mechanics with the group to kind of get us really prepped for them, because the more prep we can do with the joint mechanics and have some familiarity with it, again, the easier it is to focus on skill development and during the lab sessions. And we'll have quite a few joints to go through over in the peripheral manipulation course. But it's fun. The thoracic and peripheral courses are really good courses. You get a lot of techniques and really start to build a good skill set through them. Good. So does anyone in Chicago have any questions now that you've kind of heard us talk about it a little bit about what's coming up next week? Somebody's got to have something. If not, I'm going to have Melissa tell me about her neck, if she's still on here. Nope, not Melissa, Michelle. So Michelle, you have to share everything with everybody. But
yeah, I have a lot to talk about, I guess.
Tell me a little bit about what you learned. You don't have to go into your deep, dark details and everything else if you don't like, but just tell me about a little bit about your experience between now and the last time.
It's really interesting because, you know, I've been in PT now for, you know, going on, it's been over 2 years now. And, you know, it's just been so stuck for such a long time. And you kind of start to lose a little bit of hope that actually can get better, but it kind of goes to show you that you can kind of change a little bit of your approach for PT and how you can actually get a little bit better. So what I've been working on with Matt is incorporating a little bit more of kind of like vestibular kind of exercises and things like that into the mix, and not work on just kind of like, trying to be super, super aggressive, like you said, with like manipulations, but
Mhm.
go more into, down the path of trying to downgrade kind of pain and muscle tone, and you can see the difference in the mobility, just trying to, decrease some of that tone.
Yeah. How's it been with some of the eye exercises? Do you have any difficulty with like the eye tracking exercises, or how much of that have you incorporated?
Yeah, it's surprisingly hard. I didn't realize
Mhm.
that, that was something that I had difficulty with until I tried it. Balance in particular, like with my eyes closed, like I thought I had relatively good balance, but the second I close my eyes, it is really kind of like all over the place.
Mhm.
So yeah, it's surprisingly difficult doing something as simple as just trying to like track something. And I didn't really think about how much that kind of plays a role into everything.
Yeah. So for those of you in Iowa, when I saw Michelle when I went to Chicago, it was like, it's like one of those people you look at and it's like, okay, I know whatever I want to do, I don't want to manipulate her neck as soon as you felt it. And it's because you get multi-segmental stiffness and muscle hypertonicity. So one of the few people I could actually ever palpate the suboccipital muscles are so hypertrophic through the semispinalis, you could actually palpate them very clearly. It's the most clear suboccipital muscle palpation I ever had. And but when we tested the things that we looked at in both groups and looking at some of the vestibular and balance testing and eye tracking, they were all off. So what we felt was that, basically she has a central integration problem, and that's why she has this cervical hypertonicity. And that's why she basically had very little cervical range of motion with muscle guarding. It was very, very limited. But then you could see with like the eye tracking, the balance, the vestibular system all being off. And I think that's where I think it's good that you're kind of making those gains. And I think what I want to see is a one-to-one, is that it may not be one-to-one, but it may be a little bit slower, is that as you kind of improve those metrics, you'll see a decrease or improvement in range of motion. But I'd like to see it over the next month start to chip into your headaches.
Yeah, that's been the one thing that has been still pretty persistent, I guess. The headaches are still pretty frequent.
Yeah.
But yeah, I mean, the rotation range of motion has definitely improved. It's
Yeah.
just the extension is still pretty stuck.
Yeah. That's what I think. It's like, she has the available range of motion. It's the guarding mechanism around it doing it. That's where it's kind of, are you doing any of the neck strengthening exercises?
A little bit, yeah. We're still kind of working on more just getting it moving. We haven't added in a whole lot of like actual resistance bands quite yet.
Oh yeah, I wouldn't do resist. Yeah, you're probably not ready for that. But
yeah,
it's just some of the activation exercises, motion. Okay.
Yeah, we've been working on that for sure.
Cool. We'll take a look at a few of those things, and I'll kind of follow up with you there. And this is just nice because it's a case of where, unfortunately what we did in the last portion of the Sundays is like everything for Michelle. I think that's the portion there where we need to kind of, where your time needs to be. And then once this opens up a bit, then there's be a time, and hopefully about 2 or 3 months, where the manual then can be more effective. If you have a joint restriction, you can get into that joint and do this, and you'll be able to tolerate it. But correcting some of the vestibular, ocular, and balance problems for you, that definitely, there's some progress to be made there. So I hope it's encouraging.
Oh, for sure. Yeah, it's definitely, gives you a little bit of hope, a lot of hope actually, that you can start to get improvement even though it's been 2 years since the accident.
Yeah. So, and I'm gonna see, I may be out for, I think I'll be doing 6. If I do 6, I will spend a bit more time with concussion and looking at some of these things out there, and I'll probably in both locations. So if I'm out there for 6, I'll spend some more time there with individuals, and that kind of be good. I think it'd be a good thing to help, because I think it's a nice compliment to be able to recognize, someone like yourself and then not try and manipulate your way through it.
Yeah.
And again, that said, if it was 8 years ago, I probably would have. I probably wouldn't have had the patience or the resolve to sit back and kind of think, okay, no, this needs something different. And it's kind of what I want to kind of help with you guys too, as we talk about these things. It's not just say, hey, I'm great. It's like, boy, I failed at this for a while. let me spare you this agony or this mistake.
Yeah, I mean, I think that's just from myself as well. Like you feel stiff joint, you're like, oh, I want to mobilize it, and if they can, if they can tolerate it, then I'm definitely going to manipulate it. Just try to,
Yeah,
be
don't
aggressive.
run shot.
It's not always the best route to take.
Yeah. Oh, good. I'm glad to hear it, and we'll pull this together either as the courses go on, and hopefully by the time you roll around the next few courses, get some headway. We'll pull this together, and I'd like to see the headaches down by 50% at least.
Yeah.
In the next 2 months or so. Good. All right. Hey, hope that was helpful going over cases. I think it was good. I'm excited for you guys in Chicago. I think you have a good weekend coming your way. And as always, if you have any questions, feel free to send them to Jim or kick them over to me if you'd like. If there's anything we can do on the Zoom sessions to make them improve your experience, just please let me know. We're always looking forward to ways we can kind of improve your experience and the value you get out of these. Oh, and if Isaac, if you're still here, if you took videos at the Chicago course, at the Iowa course, send them over to me and I will post them for you. So I know you guys, somebody said they took videos, so kick them over, please.
Thanks, Dave.
No problem. I am done. You guys take care.
Thank you.
Thanks, Dave.